I'd like to think not only about crizotinib specifically, but about the class of drugs that we call molecularly targeted therapies. In lung cancer, almost all of these drugs are oral, and it's very common for patients, caregivers, sometimes healthcare professionals who are not experts in these drugs to assume that an oral drug is better tolerated than an IV drug. But the reality is that we have gotten so good at preventing and treating toxicities from chemotherapy, those are IV drugs, and immunotherapy drugs, usually when they cause toxicities, they're not serious, although the serious ones can be very serious. And so that leads us to thinking about taking an oral drug. If you take an oral drug, you're taking it every day. So if you're getting toxicities, you're experiencing those every single day. And so the fact is that not just for crizotinib, but for many of our targeted therapies, the actual experience of treatment may be more challenging for patients in 2025 who are getting chemotherapy or getting an immune checkpoint inhibitor. And so I think there's a lot of counseling that needs to be done up front, right? On the one hand, you have toxicities that you as a nurse or you as a physician can detect. You can detect a toxicity if it's a low blood count, abnormal kidney function, or abnormal liver function, because our blood tests show it. Our blood tests show it many times when patients don't even have symptoms. But there are a lot of symptoms and a lot of side effects that we would only know about if patients tell us or if we ask the right questions, right? So you can imagine that if I'm giving crizotinib to someone, the first thing I'm explaining to them is that some weird things may happen to your vision. And don't worry, it happens a lot, and we're going to follow it really closely. I'm also going to let them know, though, in general, that I want to know what side effects you're having, because severe diarrhea can be life-threatening. If people get electrolyte imbalances, that could lead to an abnormal heart rhythm, for example. So I tell patients that don't hide your toxicities from me, because sometimes people think that way. They think if I report my side effects, they're going to stop the drug and it could be helping. No, what we want to do is be able to give the drug in the very best way possible. So we want to give antiemetic drugs. We want to give antidiarrheal drugs. We want to help them with their edema. And edema from targeted therapies is pretty difficult to manage because in many cases, diuretics or water pills are less helpful than they are for other causes of edema. So we're telling people to go for lymphedema therapy or wear compression stockings or elevate their legs. But this is every day of their life. So we need to think really carefully about quality of life as we give these targeted therapies. I do think oncology nurses play an absolutely critical role. And there is no doubt, at least in my practice, that patients feel comfortable bringing up concerns, questions, or even updates about how they're doing, sometimes more comfortably with nurses and the nursing staff than they might be with physicians.